Welcome, everybody. My name is Professor J. Bhattacharya. I'm going to talk today about focus protection and using COVID-19 as an alternate strategy to the lockdown and mandate focus strategy that we have used thus far. Let me share some slides. So the COVID-19 vaccines are a fantastic tool, but only if used the right way. Thus far, we have used these COVID-19 vaccines in a way essentially aimed at eradicating the virus or reducing the spread of it. But in fact, that has been an enormous mistake. In order to build that case up and describe an alternate strategy of using these fantastic vaccines, I'm gonna need to go back in time just a little bit. So I am the co-author of a document called the Great Barrington Declaration. The document which I wrote and with two colleagues of mine in 2020, in October 2020, calls for focus protection. I'll describe that in a bit. It's motivated by two basic ideas. One is that the harm from the virus, from being infected, is extremely age specific, in the sense that people who are older have 1,000-fold higher risk of severe outcomes from the disease than children do, for instance. And the second fact is that the collateral damage from the policies that we have followed have been catastrophic. They've harmed people around the world and have likely caused far more deaths and damage, especially to the less vulnerable people, than the lives they may have saved. And finally, I'll talk about the social inequalities caused by these lockdowns, with an emphasis on how the vaccines can be used to avoid all of these harms. So I wrote the Great Barrington Declaration with two colleagues of mine, one of Martin Kulldorff from Harvard University, and then Dr. Sunetra Gupta, Professor Sunetra Gupta from Oxford University. It advocates a policy of focus protection. As I said, there's 1,000-fold difference in the risk of death from the oldest to the youngest. It's an alternative to both a let-it-rip strategy, or sometimes called a herd immunity strategy, where the virus is allowed to spread as widely as possible, and a strategy of lockdowns. Essentially, the focus has been to stop the virus from spreading altogether, perhaps even eradicate it. By the way, an impossible dream. We want to minimize both the harms from COVID deaths and the collateral damage from lockdowns. And the current policy we followed has focused mainly just on COVID deaths and not on the lockdown damage at all. The Great Barrington Declaration was signed by 15,000 medical scientists, 50,000 medical practitioners, and almost 900,000 members of the public from around the world. The reason it's called the Great Barrington Declaration is because we signed it in Great Barrington, Massachusetts, where we met to discuss COVID policy. So let me talk a little bit about the risk from this virus, in particular the harms from getting infected and the mortality from getting infected. In the early days of the epidemic, the thought was that there was a 3 to 4% mortality risk from if you were infected. This was something that the World Health Organization, for instance, said in the very earliest days of the epidemic. They were basing it on a calculation where the numerator was the number of identified patients who had COVID, who died from it, divided by the number of patients who were identified with COVID and potentially recovered from it. So at that point, in April 2020, about 3% of people who were identified with COVID died from it. Now, I ran a study called the Santa Clara Seroprevalence Study. I was a senior author of that study. It was conducted in April of 2020. And the central idea behind that study is that, in fact, for every person identified with COVID, especially in those early days when there was limited testing resources, there were likely many other people who were infected that recovered from it. This disease is an incredibly infectious disease. One person getting it spreads it to multiple other people. The idea that we in April of 2020 had only had identified all the cases with the limited testing resources we have just didn't make sense, especially since it's a respiratory virus that spreads so rapidly. In order to check this hypothesis, me and my colleagues, we conducted a study of checking for antibodies in a population in the population at large in Santa Clara County. Antibodies, as you probably know now, are formed after exposure to the virus. So if you've been exposed to the virus and recover from it, the lingering evidence of antibodies is strong evidence that you have previously been infected. If you just look for the virus itself, well, after you are better, you've cleared the virus. You're going to underestimate the total number of people who've been infected in the denominator of that death rate calculation. In fact, that's exactly what we found. In early April of 2020, 2.8% of Santa Clara County had evidence of the virus, antibody evidence of the virus. There's about 2 million people in Santa Clara County. That implies there were about 54,000 infections. At the time, in Santa Clara County, only about 1,000 people had been identified as having the virus, and there were about 100 deaths. So if we just did the math, we'd say the case survival rate was 90%. 100 over 1,000 is 10%. One minus that is 90%. Case survival rate 10%. That's a pretty deadly virus. On the other hand, if you understood that many, many more people, 54 times more people, had been infected than were identified, the infection survival rate turns out to be 99.8%, a much, much higher infection survival rate. Okay, so if you look at the age gradient, it becomes of the risk of being infected, it quickly becomes clear that not everybody is at equal risk from the virus. Children, young people, are at vastly lower risk from this virus. To date in the United States, for instance, more than 80% of the deaths have occurred in the 65 and up population. And from very early days of the epidemic, this was evident. My colleague Martin Kulldorff in April 2020 wrote an essay where he found that there was a 1,000-fold difference, looking at data from China, between the risk of mortality from this virus for people who are younger versus people who are older. This has now been confirmed by a whole very large number of seroprevalence estimates. So this is from a study that was conducted in June of 2020 in Stockholm. And the finding was these numbers are survival rates if you're infected. So for instance, for women or girls who are 0 to 9 years old, the survival rate if you're infected if you have no underlying conditions is extremely high, 99.99996%. On the other hand, if you're over 80 and you have no underlying conditions, I mean, it's a much more deadly disease. The survival rate is only 98.9%. If you have one or more underlying conditions and you're 80 years old and you're a woman, the survival rate's even lower. That's higher. Pardon me, lower. So it's 92.8% if you have one or more underlying conditions and you're a woman. For men, it's even lower. Older men, it's even lower. So if you're 80 and over with no underlying conditions, survival rate for infected was 96.3%. If you have one or more underlying conditions, you're a man. In the study, what they found was only a survival rate of 79.9%. On the other hand, if you're young men, young boys, the survival rate is exceedingly high, upwards from 99.99%. Okay, so what's the right thing to do in the context of this? Well, the lockdowns themselves have had an enormous harm, have caused enormous harm to the younger populations. We closed our schools, we robbed young people of opportunities in life. And I'll show you some of the harms, the public health harms from these lockdowns later. The right strategy, given this age stratification of risk, is to take that fact and protect the people who are most vulnerable. In this case, with this virus, this age stratification is substantially higher even than the flu. The right strategy is focused protection of the vulnerable high-risk population. Now, of course, there's still some people with chronic conditions who face a higher and elevated risk as well, and focused protection to extend to them as well. That's plank one of the Great Barrington Declaration, focused protection of the older population. Plank two is that young adults may live near normal lives, with the idea of minimizing collateral damage. For them, the harms from the lockdown far exceed the harms from COVID itself. So, for instance, letting children go to school and play with friends is essential to their health and well-being, whereas the harm from stopping that is much greater than the harm from COVID for children. Well, how should we protect the old? Well, now that we have the vaccines, that we have had the vaccines since December of last year, the priority is, the idea is to protect the old by vaccinating them first. That is as good a job of focused protection as we can do for the older population. And now, many countries have adopted that strategy, but they prioritized older populations, essentially adopted something like one of the planks of the Great Barrier Reef, the focused protection strategy, once the vaccines came available. We haven't done such a good job as a world in doing that. There's still many poor countries where many older people live that do not have access to the vaccines and will not have access for quite a while. So the idea of focused protection is to prioritize the vaccinating the old, both within countries and between countries. Before the vaccines, and actually still to this day, there are other strategies we might follow, especially in places where vaccination rates are low. So first, and primarily, like this seems so obvious now, although it was less obvious, I guess, in April 2020. Do not send infected patients back to nursing homes. That had led to an enormous number of avoidable deaths that occurred in the early days of the epidemic, simply because people did not understand, officials did not understand how steep the gradient in age risk was. Now, second, you could frequently test nursing home staffs and visitors, unless they're immune, minimize staff rotations in nursing homes, let older people work from home. If it's impossible, offer temporary retirement sabbatical. Instead, what we did was we declared two classes of workers, an essential worker and a non-essential worker. And essential workers were required to work even if they were vulnerable. We could minimize multi-generational living, for instance, by having temporary housing and letting students actually come to universities rather than closing them down. We could have free home delivery of food for older people. We could encourage people to meet outdoors, and so on and so on. The only limits to understanding how to protect the vulnerable are the imagination of public health officials. The primary problem has been that for much of the epidemic, the public health officials have relied on lockdowns as a way to protect the vulnerable, and that has catastrophically failed. How well can this strategy work? Well, let me give you a couple examples, three examples I'll give you, and then I'll talk about the United States. One is Sweden. In the early days of the epidemic, Sweden followed a strategy that was more akin to the Great Barrington Declaration, although there were great failures in protecting nursing home residents at Stockholm, where in the early days of the epidemic, just like in New York, the COVID-infected patients were let in, causing enormous death. In the winter of this past year, and the fall of this past year, there was an enormous wave of cases in Sweden, starting in October, then peaking sometime in mid-December, and huge numbers of deaths that followed. The Swedish rollout of the vaccine actually was relatively slow compared to say the United States. By March, they'd only vaccinated about 7% of the population, but every single dose went to a elderly person living in a nursing home, or or nearly every single dose went to older people living in the community. So that was focused protection. They didn't have 100% vaccination rates coverage, but what they did have was the use of the vaccine in a way that recognized the harm, the risk that older people faced. And then they had another massive spring wave of cases. You can see it in the upper figure. It's a huge increase in cases that rivaled the increase in cases that had occurred during the winter. Whereas in the winter, if you look at the bottom graph, there was an enormous number of deaths. In the spring wave, the case rise was met with many, many fewer deaths. There was a missing hump in deaths. By using the vaccine for focused protection, the Swedes had effectively decoupled the cases from the deaths. Focused protection meant there was no spike in deaths during the spring wave. That is the fruit of focused protection. Well, here's another example: the UK. Actually, a very, very similar story. Now, the UK had a much better rollout of the vaccine than Sweden did. In the winter before the vaccine, there was an enormous peak in cases in the UK, and correspondingly an enormous peak in deaths from the virus in the UK. As the Delta variant spread in June, July of this past year, there was again a huge outbreak of cases in the UK, but many, many fewer deaths, because in the interim between January and June, the UK had successfully vaccinated a very large fraction of its population, especially starting with older people first. What about in developing countries? Well, the strategies actually worked to some extent in a place like Mexico, which has had I'd say an indifferent vaccine rollout, still having trouble vaccinating. It's one of the probably in the world average. So Mexico has about if the world average is about 35 doses, 77 doses per 100 people, so 35 people fully vaccinated or equivalent. Mexico is below that at 76 doses as of February 20, as of late September of this year. Mexico started its rollout of vaccines well in December of 2020, but then in February 2021, they began the task of vaccinating senior people. So though they actually didn't prioritize the older population. Nevertheless, by July of this year, they'd used many doses to protect older people. What you can see is that, again, just like nearly every country, there was an enormous peak in cases in the winter, an enormous rise in deaths in the winter in Mexico. With the spread of the Delta variant, there was a huge increase in cases, again, rivaling the winter wave. But the number of deaths, while not flat, was substantially lower than the winter peak. The vaccine had blunted the harm from the virus. It had partially decoupled cases. And now if they'd done a better job with vaccinating the old, perhaps it would have been quite much flatter. The deaths would have been flatter, just like we saw in the UK and Sweden. The U.S., I'm going to just do a slightly different comparison. These are data from the CDC I've taken, where I calculated COVID mortality per capita per age group through September 2021, through the whole epidemic. And I'm going to compare two different states. One, Florida, which followed a much more free policy, a non-lockdown focused policy, something much more akin to the focus protection policy we talked about, versus California, which locked down very sharply. I live in California, and for instance, my kids were effectively kept out of school for almost a year and a half. The fruits of this policy you can see in this graph, where I plot the age, the mortality rate from COVID by age. For the 85 and up, California had a higher mortality rate. For the 75 to 84, California had a higher mortality rate. From the 65 to 74, California had a higher mortality. I don't want to overemphasize the difference here. These are essentially equivalent. Same thing with 55 to 64-year-olds, 0 to 50-year-olds. Florida had a slightly higher mortality rate. You can see the scale is so small. The key thing is that lockdowns, while California followed a lockdown policy, it did no better. It seems like lockdowns had literally no difference in terms of the actual outcomes and risk that patients faced when you do the stratification by age, which you must, given the high age gradient in risk. What is going on here? So one idea is one key fact about those vaccines is that the vaccines, as I said, are quite effective, but they're effective in one way and ineffective in another way. The way they are effective is by protecting people against severe disease. So this is a study, this is a graph from a study that was conducted in Qatar, where they tracked a very large number of patients over time who'd been vaccinated. What you see is that after about a month after complete vaccination, vaccine efficacy is very, very high, 95.4% efficacy. It wanes slightly, but it remains actually quite high, probably 90 plus percent, even 6 weeks, 20 to 24 weeks after the second dose. More than 6 months, they didn't have a very large sample size, but it's still consistent with very effective vaccinations, consistent with very effective protection against severe disease, severe, critical, or fatal SARS-CoV-2 infection. Vaccines are great for protecting people against severe disease. They are less good at protecting against infection. This is the same paper. This now, instead of looking at severe disease, looks at SARS-CoV-2 infection. What you can see is that in the first month after vaccination, you have 72% of efficacy of the vaccine, but that declines over time. In this Qatari study, the finding was that at 20 to 24 weeks, literally there was 0% protection at 6 months against infection. The vaccine no longer protected against infection. It just protected against severe disease. You can see this in the UK data, for instance. Why did the UK have this massive wave of cases in the summer? Well, despite being highly vaccinated, it's because it's consistent with the Qatari data. What this implies is that the vaccine will not and cannot be used to stop cases from spreading. This vaccine is not a tool for eradication or establishing herd immunity or whatever you like. This vaccine is instead a tool for focused protection. Well, the implications for this. For most of the population, COVID poses only a modest risk. Primarily, the older population is at risk, although there are some people with chronic diseases who are also at risk. The vaccines provide durable protection against severe disease, including death, but we have no technology to stop viral spread. Both lockdown and vaccines at best delay it. The corollary from this is that everyone on the face of the earth will contract COVID probably multiple times over the next few years. It's best if you are vaccinated when you contracted the first time. But the evidence is that after you've been vaccinated and you contract COVID, you'll end up with milder disease because you have severe disease protection. And even if you weren't vaccinated and you survived COVID the first time, the second time it'll be much milder. There's evidence to suggest that at a full year after you've had COVID, you're very strongly protected against a reinfection and also severe disease and death the second time you get it. Although it sounds scary, getting COVID a second time or a third time will actually be much milder. And eventually, the long-term outcome of this disease is that it will become another circulating coronavirus causing colds in the population, a population that's largely protected against it based either on the vaccine or by prior infection. Now, let's talk a little bit about the lockdown harms, because this is something that had not gotten the attention it has deserved. The public health consequences of the lockdowns are enormous and will continue into decades to come. Among the harms include things like missed cancer screenings. I'll show you some evidence on that. Worse cardiovascular disease outcomes. People skipped getting heart disease treatment because they were scared of COVID. They skipped diabetic appointments, plummeting childhood vaccination rates worldwide, deteriorating mental health, malnutrition, and starvation in countries around the world. And I'm just picked a subset. I could go on for a very long time. This is a study from early in the epidemic, looking at changes in the number of newly diagnosed cancer patients. And the blue lines on these graphs, in this graph, are baseline. This is before the pandemic. What you can see is that just in the first month after the lockdowns were implemented in the United States, there was a 50% drop in breast cancer screening, colorectal cancer screening, not quite as sharp a drop in newly identified lung cancer. I'm sorry, this is not screening. This is identified cancers. There's actually similar results for cancer screening as well. The point is that these cancers didn't go away. The women in April of 2020 were not. COVID didn't cure cancer. And so what happened is that women with cancer stayed home, and breast cancer stayed home. As a result, there will be many women who come in today with late stage breast cancer that should have been picked up earlier, who will die from their breast cancer, but not from. The way you should think about that is it's a collateral damage from COVID, from the COVID lockdowns. Same is true for hemoglobin A1C monitoring, like an enormous drop in screening, in tracking hemoglobin A1C. Hemoglobin A1C is quite important, of course, if you're diabetic and you're trying to avoid some of the long-term consequences of diabetes, like macular degeneration, kidney failure, and so on. Vaccinations. Well, the COVID vaccine is not the only important vaccine. There's an enormous number of other childhood vaccines, for instance, that prevent many times more deaths than COVID itself. The vaccination programs worldwide effectively halted because of the lockdowns through much of 2020. While there was some improvement later in the year, There's huge decrease in vaccination numbers worldwide for children. So there's at least 80 million children now, according to the UN, the World Health Organization, that at least risk of at least one of the diseases like diphtheria, measles, and polio, for which we have great vaccines. Polio actually is heartbreaking because we were on the verge of eradicating polio, and it's made a comeback in Pakistan and some other places. But these are vaccines that are extremely effective in preventing child deaths, and yet 80 million children essentially skipped getting them in 2020 as a lockdown harm. The mental health effects of COVID, the lockdowns, have been absolutely devastating. So just to give you one data point, this from June of 2020, this is a CDC study. If you look at the 18 to 24-year-old age group, 1 in 4 of that age group in the United States seriously considered suicide in the past month. 1 in 4. The mental health harms from the lockdowns are absolutely catastrophic, including enormous numbers of increases in cases of depression, increases in cases of anxiety, and these are not things that go away immediately when the lockdowns are lifted, but in fact have a long tail. And then finally, I'm going to just mention it briefly that the lockdowns have had a devastating effect on the poor around the world. The estimates suggest that at least 100 million people have been thrown into dire poverty that would, as a consequence of the economic harm from the lockdown in poor countries. And this has resulted in huge numbers of children dying from hunger around the world. So this is an estimate from I think this was from the UN, suggesting that virus tied to 10,000 child deaths each month. This is a study that was published in Science Advances in January of this past year. I'm just reading you a quote from the conclusion. Household coping strategies and government assistance were insufficient to sustain pre-crisis living standards, resulting in widespread food insecurity and dire economic conditions even 3 months into the crisis. COVID-19 disruptions killed 228,000 children in South Asia, says a UN report in March of this past year, mainly from hunger and poverty. Let me finish by talking about social inequality. We adopted a strategy, in effect, that only rich people, these lockdowns that only richer people who could afford to stay at home and not lose their jobs, could do. And we shamed poor people who, as we call them essential, effectively had to take the risk of getting COVID in order just to survive. Right. So, what part of social distancing do not people understand? That is effectively the nature of the lockdowns, extremely unequal. We protected the young members of the laptop class at the expense of the poor and the working class worldwide. Let me give you a bit of evidence on this. This is evidence from Boston. What you can see here is that as you get to places that are less and less college educated, from left to right, what you see is a higher and higher COVID incidence in Boston. COVID was not an equal opportunity disease. It affected neighborhoods with higher levels of higher levels of poverty and lack of education. But it's not actually COVID that was unequal. What was unequal was the lockdowns itself. Here's another example from Toronto. The gray bar from early in the epidemic shows the 30 lowest income neighborhoods during lockdowns, whereas the 30 highest income neighborhoods, the blue line, you see very few cases. The lockdowns exposed people living in the low income neighborhoods while protecting people living in the high income neighborhoods. Toronto and Boston are not outliers in this. And on the left part of this graph, I show data from Los Angeles County from March of this year. This is actually similar to what you could go look this up now. It's very same exact result. What you see is that in areas that are low poverty, less than 10%, only 118 deaths per 100,000 from COVID-19 in LA County. But if you lived in a high poverty area in LA County, then the death rates were more than 3 times higher. 393. And there were enormous race differences as well. On the other hand, in Florida, there was a much more equal distribution of deaths per capita by race because the lockdowns didn't happen there. As I showed you, there's very little difference in overall death rates per capita once you do the age adjustment in Florida versus California, and yet much more unequal outcomes. Here is a more systematic way of looking at this. In California, Latinos, who make up 39% of the population, have made up 55% of COVID deaths. In New York, Blacks, who make up 14% of the population, are 23% of COVID deaths. Whites, who make up 56%, are 40%. By contrast, in Florida, much more equal. Latinos, 26%, only 24% of COVID deaths. Whites, 54%, 56% of COVID deaths. The lockdowns are likely the most unequal health policy we have ever adopted in at least in the past half century. So human rights and freedoms are most important for workers and the poor. The elites will always do what they want and prosper. The lockdowns violated the human rights of enormous numbers of poor people worldwide, did not protect them from COVID, in fact, exposed them for COVID. So let me just end there. I think that we have, with these vaccines, the opportunity for a much better strategy, a strategy that is better at protecting the vulnerable, not causing lockdown harms. And I think we should adopt these kinds of strategies that have an eye toward both equity and as well as efficacy. But with these vaccines, we have the opportunity to protect the vulnerable, lift the lockdowns and the mandates. We don't have a technology to stop COVID from spreading or to get to zero COVID. That's an illusion, and an illusion that's caused us enormous damage. We do have as a strategy to stop the disease from killing the most vulnerable. Thank you.